Heart, a very vital organ of the human body. It weighs around 250 to 320 grams in an average adult female and around 300 to 360 grams in an average adult male. Now, a lot of disease processes can affect the heart. Sometimes they may affect only the myocardium or only the valves or only the cardiac conduction system or the blood vessels. But there are certain diseases which affects not only the heart but have a lot of extracardiac manifestations also. So in this session, we will see one such disease which licks the joints and bites the whole heart. So let's discuss rheumatic fever and rheumatic heart disease. Now, rheumatic fever is an acute post-streptococcal immune-mediated multi-system inflammatory disorder. Now, each and every word of this definition is very important. So, it's an acute post-streptococcal immune-mediated multi-system inflammatory disorder which occurs a few weeks after infection by a post-streptococcal pharyngitis or a group A streptococcus, that is Streptococcus pyogenes. Now, this is a gram-positive cocci. Now, and rarely it may also follow streptococcal infections at other sites, the most common site being the skin. It is common in children between the age of 5 to 15 years and there is same predilection for males and females. Now, what is the etiopathogenesis of this rheumatic fever? Now, we can have it three factors: environmental factors, the host factors and the immunological factors. So, environmental factors, the main factor is poor economy or overcrowding. So, there are more chances of spread of this pharyngitis or sore throats when there is overcrowding. Outbreaks of epidemics very commonly in crowded areas. So, environmental factors are very important. The next is host factor, that is the genetic susceptibility. So, it is said that these are more common in the families or when you have first degree relatives which are having a rheumatic fever. Also, the tendency in twins increases, the predilection of this disease in twins increases. So, that is the genetic or the host factors. Then coming to the immunological factors. Now, this is related to the streptococcal antigens. Now, what streptococcal antigens? Now, the carbohydrate of the streptococcus, that is of the group specific carbohydrate, is similar to the glycoprotein of the cardiac valves, whereas the M protein in the cell membrane of the streptococcus, M protein, is similar to the myocardial cells. Now, this antigenic similarity is very, very important because the antibodies produced against the streptococcus tends to act or cross-react with the cardiac muscle and the cardiac valves. Now, that is the main basis of etiopathogenesis of rheumatic fever. So, that is the immunological factors which are related to the etiopathogenesis of rheumatic fever. Rheumatic fever develops 2 to 6 weeks after an episode of pharyngitis. Now, this rheumatic fever slowly progresses to chronic rheumatic heart disease. Now, let us see the etiopathogenesis of rheumatic fever and rheumatic heart disease. So, initially pharyngitis or tonsillitis by group A beta hemolytic streptococci, which will give rise to humoral and cell-mediated immunity. So, remember, the etiopathogenesis involves both antigen-mediated, antibody-mediated and cell-mediated immunity. Now, after a latent period of 2 to 6 weeks, antibodies against the antigenic components of streptococcus cross-react with the cardiac antigens. So, what were those components of the streptococcus? The carbohydrate and the M protein. So, remember, the group specific carbohydrate is similar to the glycoproteins of the heart valves, cardiac valves, whereas the M protein of the cell membrane is similar to the myocardium. So, whatever antibodies are produced, they cross-react with these antigens, and that is known as molecular mimicry. And because of this molecular mimicry, we have the damage to the heart. So, activated T cells by the antigens cross-react with the self-proteins. Now, once we have the antibodies secreted will recruit more number of neutrophils and macrophages. At the same time, the T cells will secrete cytokines, and both will lead to activation of macrophages. And this is the basis of development of lesions in this rheumatic heart disease. So that will lead to pancarditis and all the other extracardiac manifestations or lesions of rheumatic fever and rheumatic heart disease. So coming to the morphology. So what are the morphological changes we can see? So first let's discuss acute rheumatic fever. So the main lesion in the acute rheumatic fever is an Ashkoff body. Now what is this Ashkoff body? It's a lesion in the heart which is composed of lot of lymphocytes. So we have lot of inflammatory cells, that is lymphocytes, which is seen. Along with that, we have lot of plasma cells, and the most important cell is an activated macrophage, which is an Enischko cell. So what are these activated macrophages? So we have lot of these activated macrophages. Now these macrophages or Enischko cells have abundant cytoplasm, lot of eosinophilic cytoplasm. The cells are round or ovoid, but when we take a longitudinal section, they appear as caterpillars, as we see here. That is because the chromatin condenses and the central wavy ribbon appears as caterpillar. So that is why they are also known as caterpillar cells. So we have lot of this Enischko cells. Now sometimes these Enischko cells fuse together and give rise to a multinucleated giant cell. Now that is known as an Ashkoff cell. Now this entire lesion is the Ashkoff body, which is the characteristic lesion of acute rheumatic fever. So Ashkoff body composed of T lymphocytes, plasma cells and activated macrophages or Enischko cells. Along with these, we have some cellular debris or necrotic debris which can be seen here and there throughout the Ashkoff body. Now coming to the morphology of giant cells. So as I already described, Ashkoff giant cells, these are multinucleated Enischko cells. Ashkoff body, it can be found in any three layers of the heart. It can be seen either in the myocardium, endocardium or the pericardium. So that leads to pancarditis. Now let us see what are the lesions in the endocarditis. Now the lesions can involve either the valves or in the myocardium. So the most commonly involved valve is the mitral valve, the left-sided valve. So inflammation of the endocardium and the left-sided valves, and what we see is fibrinoid necrosis. What we see in the valves is the fibrinoid necrosis. Now if this is the atrium and the ventricle, this is mitral valve, what we see is just some amount of fibrinoid necrosis and inflammatory cells. This is a vegetation or verrucae. Now these are small, 1 to 2 millimeters in diameter, nodular, warty vegetations which develop over necrotic foci, and that lesion is known as a verrucae. Now this one characteristic feature of the vegetation which develops in a rheumatic heart disease is these are firmly attached to the valve and they do not get dislodged. So as we see here, small vegetations which are seen along the line of closure of the valves. Now when we talk about vegetations in the heart valves, there are many other conditions which give rise to vegetations. So we will see each one. So first one is infective endocarditis. So if we see, this is the chordae tendineae, the valve. In infective endocarditis, the vegetations are very large and bulky, and they even extend to the chordae tendineae, unlike the vegetations in case of rheumatic fever. Apart from that, we can have non-bacterial thrombotic endocarditis. So in this case, the vegetations are small to medium sized, they can be multiple and they are sterile. When you study, there are no bacteria in this. So these are sterile. So these are non-bacterial thrombotic endocarditis, the vegetation seen in that. Apart from that, we have vegetations in Liebman-Sachs endocarditis. So one feature of vegetation seen in Liebman-Sachs endocarditis is it can be seen on both the sides of the valves, unlike all the other vegetations. Now coming to the next lesion, that is the MACCALLUM patch. Now what are these MACCALLUM plaques or patches? These are subendocardial lesions and they appear irregular. They are also known as map-like lesions. Irregular, these are thickening in the mural endocardium. We see it on the inner surface in the mural endocardium in the posterior wall of the left atrium. Now this location is very classical and characteristic above the posterior leaflet of the mitral valve, and most of the times this lesion is due to regurgitation of the blood, and microscopically what we see is lot of Ashkoff bodies. So what were Ashkoff bodies? These are lesions which comprises of modified macrophages, the Anischko cells, the Ashkoff cell, the multinucleated giant cells, and lot of plasma cells, lymphocytes, and some necrotic debris. So MACCALLUM patch we see here, it is seen in the left atrium on the posterior, thickened posterior valve of the mitral valve we can see, and we can see lot of vegetations here which are the verrucae. Now pericarditis. So what happens in pericarditis? So in pericarditis we have irregular deposits of fibrin on both the pericardium, visceral and the parietal pericardium, on both the surfaces, causing fibrinous pericarditis. Now that is described as bread and butter appearance. Now what is this bread and butter appearance? So it is simple. If you take two slices of bread, you apply butter on both the sides and you stick it together and try to pull it apart. The appearance what you get, that is the characteristic bread and butter appearance of this pericarditis in the rheumatic heart disease. The next is myocarditis, that is inflammation of the myocardium, and what we see here is lymphocytes, macrophages, and again the same Ashkoff bodies. Coming to the chronic rheumatic heart disease. So far whatever we saw are the changes in the acute rheumatic heart disease. Now coming to the chronic rheumatic heart disease. Now remember in chronic rheumatic heart disease, the lesions are little more deranging. The valves become more fibrotic and deformed. So the most commonly and severely affected are, it is seen in 65 to 70% of cases. The mitral valves are the most commonly affected. Apart from that, mitral valves and a combination of aortic valve in 25% of cases. Now tricuspid and pulmonary valve is quite rarely involved. What we see here is the thickening. The valves become very thickened. The leaflets become very thickened. There is fusion of the commissures where both the anterior and posterior leaflets where they close, that area is known as the commissure. So we have fusion of the commissure in which the healing of the rheumatic lesions leads to fibrous adhesions, and because of the fibrosis both the commissures come together and becomes kind of adherent. Now that leads to a characteristic deformity, what we also known as the fish mouth deformity, and we can see the vegetations here. So fish mouth deformity or buttonhole appearance, that is the lesion, that is the characteristic feature what we see in the severe disease. So the valve orifice is markedly narrowed. Now apart from that, the chordae tendineae, they become shortened and they become thickened, and there is fusion of the chordae tendineae. Mitral stenosis. So because of the fish mouth deformity, it is stenosed. The mitral valve becomes stenosed. So what are the consequences of this mitral stenosis? There will be, because of the pressure, there will be progressive dilatation of the atrium. Mural thrombi. Thrombi is like a clot which will be formed within the chamber of the heart, and this thrombi can get dislodged and embolized to different organs. There can be venous congestion because of the building up of the pressure, chronic venous congestion in the lung, pulmonary hypertension because of right ventricular hypertrophy, and which will lead to right-sided heart failure. So these are the consequences of mitral stenosis. What are the aortic valve changes? In aortic valve, we have diffuse fibrous thickening of the cusp and fusion of the commissures, which lead to again aortic stenosis. So remember, the valvular changes remain the same. It is fibrosis, thickening of the valves, fusion of the valves, leading to stenosis of the valves. Tricuspid valve changes, it is quite rare, but it can be seen in recurrent RF and it is always in association with mitral and aortic lesions. So remember, if we are seeing a change in the tricuspid valve, always and almost all the time, there will be changes in the mitral and the aortic valves. What happens is the deformed valve, again stenosis, thickening and fibrosis of the valve. Pulmonary valve quite rarely affected. Now coming to a very important part, the extracardiac lesions or extracardiac manifestations of rheumatic fever. So these are very classical and very characteristic. So first one is migratory polyarthritis. Now as the name suggests, it is migratory, means the location, it shifts from one joint to the other. It is associated or accompanied by fever. One joint becomes painful at one time, painful and swollen, that kind of recovers, then it moves on to the other joint. So it is migratory polyarthritis. Next one is subcutaneous nodules. Now this is common in children, and what these are? These are spheroidal, painless small nodules which measure 0.5 to 2 centimeters, and these are seen usually in the extensor aspects. It can be on the wrist, on the elbows or ankles, knees, and these are attached to tendons and the ligaments. So these are very characteristic lesions, subcutaneous nodules. The next feature is erythema marginatum. Now what is this erythema marginatum? These are non-itchy reddish rashes which involves the trunk and the proximal extremities, what we commonly known as the swimsuit distribution of the lesions. And these lesions have little characteristic feature. They are reddish erythematous with central clearing, and surrounding areas are little more heaped up. So that is the characteristic erythema marginatum. Next is Sydenham's chorea or Saint Vitus dance. Now what is this? It is involuntary, rapid, jerky, purposeless movements, involuntary movements of the extremities. Now that happens because of involvement of the central nervous system. So this is the manifestation. We see here, these are the subcutaneous nodules. It is present on the extensor aspect. And these are the classical lesions, the erythema marginatum. As I told you, the periphery is fully reddish and it is little more heaped up, or it is at a higher level, and the central area of clearing, that is why marginatum. Coming to the clinical features. Now clinical features, the patient can present with any of the extracardiac manifestation. It's not necessary the patient has to present with some symptoms, some cardiac symptoms. So patient can present with migratory polyarthritis, subcutaneous nodules, erythema marginatum, Sydenham chorea, or even the patient can have cardiac murmurs, arrhythmias, or thromboembolic complications. So the presentation of these patients can be very varied, and it might be totally unrelated. So we have to know these lesions to come to a diagnosis. Coming to the diagnosis. Now how do we diagnose rheumatic fever and rheumatic heart disease? Now there are a set of criteria popularly known as Jones criteria. Now what are these Jones criteria? So it is classified or divided into major manifestations and minor manifestations. So what are the major manifestations? First is carditis. Remember, it is pancarditis. Migratory polyarthritis, Sydenham's chorea, erythema marginatum, and subcutaneous nodules. So these 5 are the major manifestations in the Jones criteria. Minor manifestations include clinical and laboratory manifestations. So clinical, fever and polyarthralgia. Remember, this is just polyarthralgia. It is not migratory polyarthritis. It is not shifting from one joint to the other. Laboratory features include raised ESR, increase in the total leukocyte count, acute phase reactants like C-reactive proteins, those will be higher. ECG, there will be prolonged in the PR interval. So these are the minor manifestations. Now, how do we diagnose? So for diagnosis, we need first a supporting evidence of preceding streptococcal infection within the last 45 days. So what is this evidence? So the antibodies against the streptococcus, that is elevated rising anti-streptolysin O or other streptococcal antibodies, or a positive throat culture, or a rapid antigen test which is positive for the group A streptococcus, or a recent scarlet fever. So we have to have any of these preceding feature or preceding evidence, supporting evidence for streptococcal infection, plus 2 major or 1 major and 2 minor criteria. Remember, it is 2 major or 1 major and 2 minor criteria. So that's how we can come to a diagnosis of rheumatic fever, rheumatic heart disease with Jones criteria. So coming to the laboratory findings can be serological tests in which we look for antibodies to these streptococcal antigens, and those are anti-streptolysin O, DNase or anti-hyaluronidase. Apart from that, other manifestations or other investigations can be acute phase reactants like raised ESR or CRP, that is increase in level of CRP. So that gives a supportive evidence. So what can be the complications of rheumatic heart disease or rheumatic fever? So these vegetations what we talk about in the rheumatic heart disease, they can get infected, and that can lead to infective endocarditis. So that's a complication of rheumatic heart disease. Thrombi, the mural thrombi formation can occur within the chambers of the heart. Those thrombi may embolize to different areas, so thromboembolism. Congestive heart failure can occur. Adhesive pericarditis can result as a complication of rheumatic heart disease, arrhythmias, and lastly, sudden death. What about the prognosis of the disease? Now, the course of the disease, usually the acute attacks will subside within the first 4 to 6 weeks, and especially when antibiotics penicillin is given, it helps in protection from it progressing to the rheumatic heart disease. However, long-term prognosis can be highly variable. It depends on multiple factors, the host immunity, how much of antibodies are produced. It is very, very variable. So what can be done? The valves can be repaired surgically, or sometimes even replacement of the diseased valve can be done. So now let us just summarize rheumatic fever and rheumatic heart disease. So rheumatic fever is an acute post-streptococcal immune-mediated multi-system inflammatory disorder. Now remember, each and every word of this definition is very, very important. Now it occurs a few weeks after infection by group A streptococcus, that is the pharyngitis or the sore throat, common in children between 5 to 15 years of age, and etiopathogenesis include 3 factors: the environmental factors, the host factors, and the immunological factors, that is the antigens of the streptococcus. Morphologically, we have the characteristic Aschoff bodies, VERRUCAE, and the MACCALLUM plaques. We can have pancarditis, that is endocarditis, myocarditis, and pericarditis. Remember the bread and butter pericarditis here. The valves can be deformed, valvular deformities, the fish mouth appearance of the valves, and the extracardiac lesions. Now, Jones criteria are the one we use for diagnosis of rheumatic heart disease. Laboratory findings include the serological test for the antibodies against streptococcal antigens and the acute phase reactants. Complications, it can range from arrhythmias to thromboembolism to different mural thrombi formation, and it may even lead to sudden cardiac death. So that was about rheumatic fever and rheumatic heart disease.